Buonasera, benvenuti a GiovedìScienza.
Good evening, welcome to GiovedìScienza Science on a Thursday. We are in the main lecture hall of the University of Turin. I would like to remind you what the gong is for. Many remember, but it's a good idea to remind us, and in particular to remind the two people who are sitting next to it. The gong is there because they can use it to interrupt once each, at the most, to interrupt our lecturer once, if and when they consider it necessary. Only once, though. Sometimes it's a surprise, sometimes it isn't, and they can ask questions, ask people to re-explain things, and so on. My name is Lorena, and what are you doing here? Well, I'm here to gain a better understanding because I am studying at the Turin Polytechnic, so nothing to do with the topic. Well, you don't know. We'll see.
Buongiorno, sono Giraudo Isaac, sono specializzando in pediatria.
Giraudo Isaac, and I am specializing in pediatrics because I wanted to better understand regeneration and to ask a question.
Questa sera che è seduto di fianco a me.
Now I would like to introduce today's speaker, who is sitting next to me, Francesco Segreto. Francesco Segreto, I should address him in the formal way, but I'm going to speak to him in the more informal way. He is a specialist in reconstructive and plastic surgery, and reconstructive is the key word here, because in future maybe it should be called regenerative, but let's not talk about it now. He is working at the campus university in Rome and is now working at the oncology department in Milan. Allow me to explain why we would like to speak in more informal terms, and that's because we met last year at the GiovedìScienza Prize, and then he was awarded the prize, he was the winner, so a round of applause to encourage him and to remind him of his successes. The GiovedìScienza Prize, which is now in its 7th edition. You will find it on the website GiovedìScienza.it. Any researcher in Italy under 35 can compete if they have an interesting research project. They have to send a description which will be assessed from a scientific point of view, but above all, or at the same time, they have to have the will and the skill to tell the story.
Proprio su questo aspetto il nostro relatore Francesco.
Let us put our speaker to the test, Francesco Segreto. Please take the floor.
Buonasera, innanzitutto grazie Alberto per la splendida presentazione.
First of all, thank you very much for the wonderful presentation. Thanks to all the GiovedìScienza Science on a Thursday staff for the organizational effort both last year and this year. I'm going to start and without any further ado. As Alberto was saying, I'm specializing in plastic surgery. What do you expect from plastic surgery? This is the media description: beautiful girls, expensive cars, and why not holidays in Miami. In fact, it's all very different. I would like to introduce someone. I will be introducing several people. This is Joseph Murray. He was a plastic surgeon who worked at the Brigham and Women's Hospital in the Harvard Medical School, and he was the person who carried out the first transplant in 1954. In fact, it was a kidney transplant, and because of this, he was awarded in 1990 the Nobel Prize for Medicine. Imagine how many lives have been since saved thanks to the technique that he developed. And this is a story which I'm pleased to tell you, but it also talks about what the importance is for our science, that is science, creativity and technology, merge together and act synergically for our final aim. That is to say that form and function should work together. It has a very old root, and in the course of time, we'll see how many years now several techniques have been developed. Let us talk about a reconstructive score. That is to say, there are a number of increasingly complex techniques that are aimed at correcting defects, faults, problems, which may be even very severe. In the first step here, we have grafts. What is a graft? A graft is a transplant of a tissue from a donor to a receiver, interrupting the vascular continuity. Let me reword this. This is the skin. This is a section of the epidermis, and if we cut the skin at this level, we are detaching it completely, and we can reposition it in another place, very simply, so long as there is vascularization in the receiving area. The skin then becomes functional, and it becomes part and parcel of that tissue. The first experiments were carried out in 1804. Baroni published this book for animal grafts. What do? You take a portion of the skin, and here there is a first premise. There will be a series of quite strong images, and I hope that I won't be ruining your appetite nor your sleep because of it, but you will have to see some very strong images. This patient received a reconstruction with a graft. Very simple technique. It can also be done in patients who are quite ill, but there's a major problem. The aesthetic result is debatable, and in fact, sometimes very bad. So we had to invent something else. In fact, in this way, you can transfer skin or cartilage, but it's impossible to transfer muscle like this or graft it on. So we needed to invent something else. In the second step of our score, we have flaps, pedunculated flaps. What is it? It's the transplant of a tissue from a donor site to a receiver site, maintaining vascular continuity. Please look at this image, and here you see in particular in this figure, the skin is left in continuity, which means that it is fed by the blood vessels, even at the border passing from there. Where the skin is completely cut off, it comes from down below. This is quite an old technique. This photo, top left, is from a Tagliacozzi book. He was a professor in Bologna, considered the father of plastic surgery 1500s. It's called the Indian flap because it was also found in Indian manuscripts 600 BC, and it was also used in those days as a punishment. What you do, you take a flap of skin from the arm and you got it to be grafted on the nose. The patient was left for 3 or 4 weeks, which meant that the tissue was revascularized, and after 3 or 4 weeks, the arm was then mobilized. The flap was resulted, and what happened was that the nose was covered, and this technique was very fashionable. In fact, especially in world wars, where it was necessary to address injuries due to weapons, people could be used. Here you can see a wax model during World War I to teach young surgeons how to cover the losses and even to operate on the battlefield. These techniques nowadays are no longer used. We look at them as a historical artifact and in fact look kindly on them, thinking of the early days. But nowadays it would be unacceptable to leave a patient for 21, 28 days with an arm attached to their nose. Here we've developed a technique. This was a patient I operated on. He had a cancer of the nose. And this is the same patient 3 months later. It's as if he hadn't had anything. And again, and here we have the stronger images, this woman had a problem after a cancer had been removed. And here we had to take some tissue, some skin from her forehead and so on. And this is after 6 months. Here is another case, again, a patient who had had cancer, and once again the result is very satisfactory, also from an aesthetic as well as a functional point of view. However, there is a problem with this technique, and that is to say that you don't always have tissue close to the area that has to be covered. Here we're very close to eyelids or to areas that are functionally and aesthetically very important, which is why you can't always take skin or other tissue from the area close by. So we had to invent something else, which brings us very rapidly to the 1970s, when the first cases of free flap were used. What's this? It's transplanting a flap of tissue, interrupting and then reinstating vascular circulation. What does this mean in not so medical terms? Look at this. This is a part of skin with the vascularization of an artery. We can detach it and reattach it on the artery of another area, which is the receiving area. How do we do this? Here, this is an enlargement. Imagine what it means that you have two tubes, 1 2 millimeter in diameter, and having to stitch them with 6 to 8 stitches, and the suture has to be so perfect that the blood will flow without coagulating. We're talking about advanced techniques that were greatly developed from the 70s onwards. They also have the great advantage that they make it possible for us to go beyond the skin, beyond the epidermis. We can also do it with bones or combination of bones, muscles, and epidermis. And here, this was the most reconstructive area, the last 30, 40 years, where we invented different things. For instance, this is a technique which is called DIAP, and which is a dream of many women. That is to say, to reduce your stomach and to build up your breast, and that is what we use, for example, after the breast operation. The vessels are reconnected to, say, the inner mammary artery and so on, and we can reconstruct the breast without a prosthesis. Although the prosthesis give very good results, this is the patient's tissue, so it'll age with the patient, it is fatter or thinner, and doesn't replace replacement, while very often after 10, 15 years, a prosthesis has to be replaced. But we went even beyond. This is what architects would call an exploded image. That is to say, the details are shown. And here you can see the various components. You have skin, the bone, the tendons, and above all, the vessels, which are the ones we're most interested in, because they're the ones that nourish and enable the survival of this tissue. So we have nerves, arteries, and veins. Imagine what happens if you have an accident like this and you no longer have a thumb. You can't work without a thumb. And even the most common gestures of everyday life are not possible. You can't hold a glass. You can't even really feed yourself, hold a fork, hold a knife. Luckily, Mother Nature has given us also a big toe. So the idea was transferring the big toe to reconstruct the thumb. And not only does the big toe become an opposable finger, which means it's functional, but I mentioned the nerve because by reanastomizing it, if we consider that the big toe was taken to the thumb, you also reacquire sensitivity. It requires months, but this thumb is totally functional in terms of both grasping, but also sensitivity and feeling, which is essential to control the strength that it has to have. And so we started increasing the difficulty. So now we can reconstruct the distal phalanxes. Why is it important? Because the anastomosis is very difficult in this case. We have very small vessels, and it means that we have to give them those 6, 7, 8 stitches. So there's a problem with this technique, which is beautiful, but it needs a site. Of course, the thumb is more important than a big toe from an aesthetic and functional point of view, but there's always a problem with the foot then, and the harder the technique, the greater the balance that we have to recreate. So it means that the general conditions of the patient must be good, and with older patients and clinical problems and progress in medicine, we are increasingly treating patients who are old with an overall clinical condition that is not good. Microsurgical techniques cannot always be applied to these patients. This is why we need regenerative medicine. What is regenerative medicine? It is, as you can see here on the slide, an interdisciplinary field of research and clinical application focusing on the repair, replacement, and regeneration of cells, tissues, and/or organs in order to restore impaired functions resulting from any cause, including congenital defects, diseases, traumas, and aging. It's very important to notice how and why this is an interdisciplinary field which involves cell biology, tissue studies, but also science of materials and transplant, because many of these can be transplanted then. In plastic surgery, there are several solutions for regenerative medicine. We have replacement. Here we have plasma-rich platelets. That's PRP. In the past 10 years, we've been using stem cells. And we're projected towards nanotechnologies, biomaterials, and 3D printing. Let's start with dermal substitutes or replacements. They're matrices that give a substratum for the regeneration of the skin, similar like human tissues, which in one way trick the organism, because when we put it on the wound, what we don't have a fibrosis regeneration, but a migration. And so you get dermal rather than scarring tissue. It means that the organism recognizes them as their own or quasi their own. Very important in part for the regular wounds or the wounds that we will see it in this moment for chronic ulcerations. So where do you get them from? There are various sources that you can see in the US and other countries. You can use human derma without cells from a cadaver or a dead person, while we can also use matrix or matrices from pigs or other animals. So the derma is treated, decelled, so that it is not recognized as external from or like something which is not their own by the organism, and therefore it doesn't trigger the immune system. These are a chronic ulceration which the patient has had for more than 5 months. And here we've applied a dermal replacement in combination with a graft. What I showed you earlier later on, and this is the result. See how the result has changed. Very different also aesthetically in this case. The graft was favored. This is quite a delicate area because it's close to the ankle, and we have the malleolus. And then we move on to the second use, which is the PRP, the platelet-rich plasma. This is a platelet. This we're inside a vessel. The platelet has receptors. The receptors recognizes the damage and therefore is activated and produces growth factors, which on the one hand recall other platelets and start the healing process for the tissue. So we asked ourselves, couldn't we use this mechanism without the damage? Is there some way in which we could use and isolate these growth factors, these platelets, without the damage? And the answer is yes, it is possible to do so. How? You take some blood from the patient. This blood is subsequently centrifuged with a specific protocol, and this enables us to separate the plasma in the various components. There is some which is platelet poor and one rich in platelets, and the lowest we have some red blood cells. And we will use the PRP, which is then applied or injected on the receiver side with very different, for very different reasons. Clearly, we're talking about PRP, but there are very many different ones. Which one can we use? Well, it depends on the reason. For example, here you can see in the cases of ulcerations, and here we have a PRP which is rich in leukocytes, variating the centrifuge protocol. We're able to isolate as well as the platelet, also the white blood cells. What's the advantage of also isolating the white blood cells is that we can have the regenerative power of platelets with the antibiotic effect of the white blood cells, and this is comparable to some antibiotics. This is very important because if you imagine a chronic ulceration where there's not much blood inflow, so the antibiotic doesn't spread, not only, but in fact we've recently heard of the increase of antibiotic-resistant infections due to the overuse of antibiotics. But with a method like this, clearly this type of complication is greatly reduced, and we can use PRP in the case of an infective wound as an alternative to systemic antibiotic. Here you can see some cases because wounds usually heal very rapidly, but this is a patient who's very elderly, suffering from diabetes, and who has also a staph, which was a antibiotic-resistant staph infection, very difficult to fight. These are cases that when they arrive, we're really a bit worried about it. And in this case, first we used advanced medication, and then we also applied an injected PRPs, and after 3 sessions, 2 weeks later, and this is after 5 sessions. The leg is still atrophic. We can't really do much on this and diabetes, but in any case, what we were able to do was to get the wound to heal. And it's not just ulcers, but also the aesthetics that are important, which is a very important branch for us too. And here I'm showing you some less hair-raising pictures to anti-aging, for anti-aging or for the treatment of alopecia. How do you do that?
questa terapia si utilizzano due principi. Questo qui è quello dell'induzione collagenica percutanea, ossia ci sono degli aghi.
In this treatment we use two principles. This is collagen. There are microscopic needles with very small holes, and this makes it possible to penetrate the drug without any injections in the first phase. And there is a widespread penetration throughout the surface of the PRP. Then subsequently you also inject in the deeper layers, and the result is that there is a rejuvenation of the skin, and these are some of the results. This is a few days after the treatment, or if people want a hair transplant, so this is the result after 2 sessions. Let us move on to stem cells and to the injection of adipose tissue. It means transferring fat from one to the other areas. The history of plastic surgery is strongly linked to transplants and grafts. It's from 600 BC. But in 1893, this gentleman, this doctor, who was a German doctor, transplanted fat, adipose tissue from the arm to a cheek. Now, the problem is always whether it'll take in the new area or the new location. He used a very simple trick. That is to say, he used very small portions so that the tissue surrounding it was able to revascularize it. Subsequently, in the course of the 20th century, several techniques developed with results that were variable. That is to say, some were good, some weren't, some of them but the technique had virtually been abandoned by then. But then in the 1990s, this gentleman, Dr. Coleman, who's still alive and still operating in the US, standardized the fat tissue grafting. What does this mean? Well, basically, you take fat with a cannula. The cannula is connected. This is a liposuction, which is what you also do for liposuction for aesthetic reasons. This fat is then centrifuged, again with a very specific protocol, and the centrifuge means that it is separated in its various components. In particular, here you can see the oil which is released by the adipocytes, so that are the fat cells, while these are the cells themselves which we have to graft. Lower again, we have an anesthetic, a local anesthetic that we infiltrated, and these are red blood cells and other cells, and we'll see what they're for. So basically, this portion, this yellow portion here, which are our adipose cells, are then grafted to fill in, as we can see it in this case, a defect of the lower eyelid and to fill the eyeballs. It's injected through very thin cannulae, and the important is that you have a minimal amount each time, because the receiving tissue, the healthy tissue, must be able to absorb it and has to revascularize it. A new revolution was the one which followed the discovery of adipose stem cells, 2001. In the 1990s, we used to carry out this fat transplant, filling them in, but we noticed something. That is to say that there was also a regeneration, and that the skin itself changed, and that, for example, some hyperpigmentations disappeared, and we wondered why. How was this possible? How is it possible for fat to give this type of effect? And this is the answer. Because in the fat that we were injecting, there were also some stem cells, and specifically stem cells are part of a regenerative pool, which is the vasculostromal fraction, which has fat cells, but also circulating enteral cells. So let us call them adipose stem cells, and they have the various advantages. First of all, they can differentiate, and they can become mesodermic, endodermic, or exodermic. That is to say, they can become fat, bone, or also smooth muscle or cartilage, but they can also become a heart muscle or even neurons. And this is something which is extremely important, because it means that they're extremely versatile and can be used in different places. And also they have no ethical problems that might be associated with other stem cells and that have been debated over the past few years. Another advantage is that it's very simple. It's minimally invasive. It doesn't require anything special, simply a cannula and a liposuction. So we had a sort of gold rush, a scientific gold rush for the use of these cells. So, for example, they've been used in the regeneration of peripheral nerves. They've been used also for multiple sclerosis, retinopathy, and also in post-infarction heart cells. These are cases, these are not from me, they're from literature. And in this case, you see a woman who'd had radiotherapy. Radiotherapy damages tissues, and it's a permanent damage. And we saw that using these stem cells, this damage, in fact, is reduced. And this has also helped in the reconstructive surgery to improve the function and the shape of a post-mastectomy breast. Again, here, adding the stem cells to the fat cells, it was possible to increase the size of a breast without having a prosthesis. This was a study that was carried out in Japan, once again. And here, what I was talking about with reference to the coloring of the skin. Here you can see that in post-operatively there is no coloring. Again, talking about pathology here. It was used to prevent bed sores. That is to say, when a patient is in bed, when you can see and appreciate bed sores, the first stage is the deep tissue injury. And it is a stage where you can still do something, where the damage is reversible. And in this stage, if we work with adipose cells, we're able to stop the progression of the bed sore.
Buongiorno. Allora, abbiamo visto tutte le proprietà che queste...
We've seen all the various properties that these stem cells have or can have in differentiating the various lines. We also saw the application in adults. Well, what about children? And say, for example, congenital malformations. What are current applications and what are the future prospects that this approach might offer? Thank you very much for the question. It's very initial there. This type of experimentation on children is much more delicate. In fact, on the animal model, we're experimenting, for instance, both as far as the cleft palate and hair lip. Several studies have been using this to favor the regeneration of the tissue, which is obviously missing in that type of malformation. As far as the in vivo application on embryo, it's very early days. Thank you very much. Here's the problem, that is to say, adipose cells are about 1 or 2% of the tissue. So to increase this, we have to increase concentration also, because there's a big limitation, and that is to say that the amount of adipose or any other tissue that the receiving tissue can accept. For example, if we're in an ulceration or in any other type of reception, if we put a larger amount which exceeds the perfusion of pressure in that area, everything will go into necrosis, because by increasing pressure you don't get the blood. So it was necessary to find how to inject as much as possible with the least damages. Between Japan and the US, they've invented these techniques, which meant that the fat was treated with an enzymatic treatment with subsequent re-injection in situ. But again, here we had another problem. First of all, that this method was quite expensive and required a dedicated facility and staff only for that. And then it uses enzymes such as collagenase, which are not authorized for human use. So it was forbidden in many countries, including Italy, other than experimental protocols that had been approved. And henceforth, we developed the stem graft. The stem graft means that we take the adipose tissue to develop a regenerative matrix with a lot of stem cells with a minimal manipulation, and which is consistent with Italian legislation. We don't use enzymes, only mechanical means. What do we do, for example? First of all, we use the lower abdomen because this is the area where there is the highest concentration of stem cells. The infiltration of anesthetic is also optimized, and you use an anesthetic which is not toxic for these cells that are resistant but can be damaged by certain types of anesthetic. This is, you see, is us taking it. It's a calendar. We aspire. The cannula doesn't damage any of the vessels. It doesn't cause damage. And this is the fat, the adipose tissue, which we're then going to process. And how are we going to do this? First of all, we centrifuge it. And this makes it possible for us to separate the various components. We then remove the oils. We remove the infiltration. This is the local anesthetic, which we infiltrated before carrying out the inspiration. And then we keep the adipocytes, as in Coleman's technique, and this lower layer where there are the red blood cells and where some cell types are found, and we're particularly interested in these for regeneration. Then, with this mechanical, very simple method, there are two syringes. We fragment and destroy all the adipocytes. In this case, we don't want to give volume. We don't want to fill anything. We don't need the adipose cells. We simply wanted to find the stem cells. It's for regeneration. And we recentrifuge this with a specific protocol and see what happens. It's different from the one we had before. This liquid, which is oily and yellow, what is left after the fragmentation. It's toxic. It gives an oxidative reaction. We therefore eliminate it, and the anesthetic residue. And what remains is our stem graft. That is to say, a matrix which consists of adipose stem cells, endothelial cells, and precursors of the vascular cells, that has the big advantage that it is highly concentrated and that it can be injected with a very thin needle. Why is it important that it is a thin needle? For what I was saying before, because what we have to do, we have to be sure that there is much tissue as possible around the cells. Not only that, but there's another advantage is that we can use also in sclerotic fibrotic tissues, such as chronic old age ulcers. And these are some of the more clinical results from the lab on the % increase in the stem cells. Here we've seen that these are not only numerous, but are also able to differentiate and are therefore functionally valid. This brings us back to the clinical application and to chronic wounds. You see, these are wounds that are smelly and which requires a change of the medication every 2 days with constant pain by day, by night. In a case like this, the patient can't really walk because it's virtually an Achilles tendon, and that leads to social isolation. It's not so rare because we're talking about 3 to 5% of the over 65s. That is to say, in this moment, there are between 400 and 600,000 people who are suffering from it. A city which is about 2/3 of Turin, of people with ulcers who, as well as the problems we've described, are a time bomb that is ticking because there may be complications leading to gangrene, sepsis, and the amputation of the limb, and possibly the death of the patient. In this case, this was a patient that we treated in the campus in Rome who had an infected with a Staph aureus infection. with Pseudomonas aeruginosa, and this is the result 6 months after the treatment with stem cells. And yet again, this is another case. This was a patient I was particularly interested in. This was a vascular ulcer, and we put the dermal matrix from it was porcine, it was pig, but this is the result after a few days. Why? Because some things don't work. Even when you do things for the best, sometimes things don't work out. So in this case, the patient had a reaction probably to the matrix or in the vascular conditions of the limb were worse, and so there was a strongly inflamed one. We couldn't repeat this type of treatment. So what did we do? For some days, we treated the patients for the infection to regress, and then we used the stem cells, and this is the result after 5 months, 5 or 6 months. Yet again, this is a post-traumatic ulcer. This is again on the Achilles tendon. Patient has had it for 10 months. Patient was nearly 60, hadn't reacted to the early treatments with PRP. And again, this is an infection which was an MRSA infection. Here we have a graft, adipose, not cutaneous, but adipose, and we associated to PRP. The PRP had failed to use. It started to work. This was after the graft, 3 sessions, and basically the wound healed. Again, this too is another patient I'm particularly fond of, a football player, soccer player, and had a trauma with a laceration of the tendon, which also happens for a football player, which often means the end of the career. We operated on him with the orthopedic surgeon, reconstructive surgery, reconstruction of the tendon, beautiful, wonderful, but after a few days, after about a fortnight, there was an infection with an exposure of the tendon. These are very delicate cases because on the Achilles tendon, we haven't got the skin. The skin is very close to the surface and to a tissue which you move continuously in the course of a day. So what did we do? In this case, we had to combine several techniques. We used Graft, we also used the PRP, and here you can see the result after a few months. Not only has it done, but he has fully recovered functional. This was also we had a gait analysis, and he even played football. He was no longer professional, but he was absolutely able to play. And now a look into the future. 3D printing, it's something which currently we're starting to talk about in a more convincing manner, also thanks to technological progress. So what is this 3D printing? Well, it's a technique which makes it possible to assemble cells of biomaterials and biomolecules controlled in the space to reproduce the micro and macro architecture. You can see this here. What is the development? Well, say that you have a fault, you then have the image with a CT scan or other forms of imaging. This is processed with a specific software, and then the organ is recreated, or the scaffold for the regeneration of this in vivo. Very beautiful, very suggestive. We're getting there. In fact, currently several studies have shown how it is possible to have 3D printing and how to create muscle, skin, cartilage, bone, fat, blood vessels, and nerves. We also have some limitations. We're talking about processes that require a clear definition and a clear, very high definition of printing. We can only use biocompatible materials, and above all, cells are not easily treated, and in fact sometimes are ill-treated, and we have to see whether they're able to operate or work where they are grafted on. Let me give you an example. The Cyborg, this was an article that was published in 2013. And what did the authors do? They recreated an ear using a matrix of alginate printed in 3D with chondrocytes. These are cartilage cells, and silver nanoparticles. Why silver? Because it is a conducer, and that made an interface between the solid structure and electrodes, which were in the shape of a cochlea, where we're talking about a cyborg ear, because this, in fact, reacted to electric frequencies. What does that mean? What is the future of this? That in patients who need it, we can put an ear that transfers a mechanical signal into an electrical one. And the electrical one is the exchanger, because our brain uses and reads electrical signals. So we could have an ear that is absolutely functional. We're not yet there, but I hope we will be there soon. Here, I'm reaching the conclusion. I offered a number of cases and people. This is John Quincy Adams, the 6th President of the United States of America. Ah, the gong.
Chiedo scusa per interromperla, prima di tutto.
Pretend it is a surprise. Please excuse me if I interrupted you. We saw several methods that were used in reconstruction. But as far as, for example, baldness is concerned, people as well as grafting of PRP and URC transplants, which, in your opinion, is the best or most effective method, the one which has a future? Well, here, in fact, this is there's a number of conflicts of interest here, because there is scientific evidence that shows that the PRP is effective in the case of baldness. Early studies had very contrasting results, so much so that there were some people who questioned the method. Now, in the past 4 or 5 years, in fact, several or a certain amount of evidence has been produced showing the effectiveness. But in surgery and medicine, you have to decide what the indications are, because the PRP in the case of hair will lead to the recovery of the bulbs that are suffering, but that are becoming atrophic. But where there is no more bulb, or it is totally atrophic, here you have to have a transplant. But here again, we're talking about PRP, but there are different types of ones. They have regenerative units. Well, there are several ones with the PRP, and the evidence is still debatable. That is to say, there are things which we are still trying to find solutions for, ideal solutions. Currently, there are also people who have tested adipose cells, and others have also carried out murine studies or studies on a mouse that are encouraging. I think that in the next 3 or 4 years there will be a standardization. Thank you. And now, in my conclusion, I was saying, what's John Quincy Adams got to do with all this? If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. He had expressed this thought, which has become a famous aphorism in the course of a business administration course. And it's important, the dreaming more, learning more, doing more, becoming more. What's this got to do with plastic surgery? I showed you the Miami Beach, the nice girls, and so on. But in fact, this is what the meaning of our surgery and of all scientific research is. That is to say that it must be enable the patient to become better, and in the case of aesthetics, to dream more. Thank you very much for your attention.
Grazie a Francesco Segreto. Abbiamo
Thank you very much, Francesco Segreto. We have time for questions from the audience, so if there are any questions. Third row there. Yes, there's one thing that I'm not very clear about. When you showed that technique with the syringes at 90 degrees centigrade that were destroying the adipocytes and that were going to select stem cells, how does this technique destroy adult adipocytes and not the stem cells? Because stem cells are smaller and more resistant. And therefore, the turbulent movement damages adipocytes that are basically you can imagine them as oil-filled cells. The turbulent movement gets them to explode. So, in fact, adipocytes become residues. They're only residues and fragments, which are useful for regeneration and that are interpreted by the organism as a tissue damage and therefore trigger the anti-inflammatory activity, which is what we're seeking. The oil is eliminated because it can cause damage, but they're not only stem cells, but also these fragments of the adipocytes, which are very useful for the final aim. A question over there? Good evening, thank you very much. I would like to say that fat is beautiful, and I'm referring to myself to stem cells that come from adipose cells. Are they the future compared to the other stem cells, in particular the ones which have led to a number of arguments? And then I've seen something else, images referred mainly to wounds or things that are on the border of the human body. Have you also carried out internal surgery? Not only the ear, but say heart, kidney, and so on. Thank you very much for the question. Adipose stem cells are not the future, but also the present. And they're progressively replacing stem cells from other districts, other tissues, and we've seen that they are very effective. And what we're seeing, while 10, 20 years ago experiments were carried out with those stem cells, now they've been repeated with adipose stem cells, and there's a very high level of satisfaction. They're much better. As far as internal organs are concerned, we use this graft, for example, in the case of radiotherapy damage after mastectomy, and there it is with a classical transplant to give volume, but I'm not involved in the splanknology in the internal organs, liver, kidney, and heart. I have no personal experience of the clinical implications of these stem cells in living patients. It's not my field. I have a question. How many of you in Italy are involved in this area? And how many people are looking after those 400,000 to 600,000 patients who have those chronic wounds? There's a growing number. I don't have the exact number, but I believe that, honestly, about half of these patients have access to good treatment. And as I was saying, there's been a sort of gold rush on these topics. And there are centers in Italy which have been working on it, that are working on it. In this case, the problem is standardization, because as all the new things in medicine, we have to understand which one works better, which ones are cheaper, which can be applied to the larger number of patients. And so there are still major differences between one center and the other in the protocols. But again, I think a little at a time, we will have a standardized treatment.
No, sì, certo, non ho visto dov'è.
Viene di qua. Ecco. Nella popolazione che invecchia...
The aging population, we often hear speaking about a cartilage that need to be replaced or say they're worn out. There's arthritis, arthrosis, degenerative diseases. So I'd like to know what there is, in fact, because these seem to be untreatable conditions. Can we use this, for example, using biomedical materials or to reconstruct cartilages? And the question I have is also, why does cartilage wear out, and why does the orthopedic surgeon says walk more or move more? If they're worn out, wouldn't you be better off by not walking? Thank you.
Andiamo su un campo più ortopedico. Fondamentalmente noi dobbiamo immaginare le cartilagi.
Here we're going on a more orthopedic area. We have to imagine that cartilage or any tissue of the organism is something which is in progress. Cells die, cells grow, cells die, cells grow. And this is throughout our lives. At a certain point, the balance between the cells that die and the produce of these cells is negative. That is to say, we have more cells that die as compared to the ones that grow, that are metabolically alive. The orthopedic surgeon will say walk because by stimulating the cartilage, you will stimulate the metabolism and possibly the production of hyaluronic acid, and this increases the work of our joints. But this is orthopedics, really. The use of our techniques in orthopedics, well, yes, this has already happened. We use it in particular for degeneration due to arthrosis and arthritis, and we use it both in PRP but also in adipose tissues. And in fact, it is also used in some diseases such as Raynaud's syndrome, which may be isolated case or part of another rheumatic number of diseases, because there's a spasm in the finger which leads then to the ulceration of the fingers themselves. And in this case, we've seen that by injecting these stem cells, these crises are reduced because it's an immunomodulator in effect. It reduces the inflammation in vascular and local areas. And these are treatments that are currently being used. In the hospital and the biomedical campus, the orthopedic surgeons are already have been using it for a couple of years. Good evening. Well, in your report, you were mentioning the use of stem cells in retinopathies. Since I am interested in this for a person in my family, I would like to know if it is possible to have some details on where research stands. Yes, the study which I was referring to is still on animals, which means that once again, since it is not my field specifically, I don't know if they've already moved on to experiments on human beings. I know that something was being done in the United States, and this a few years ago, but the problem was that there were complications, and so they had discontinued experiments because there'd also been some problems in authorization, and so that particular experience was discontinued. Currently, I don't know if in Italy there is someone who uses it. Honestly, I can't answer that question.
Volevo sapere, nei casi che sentiamo di cronaca di
devastazione,
devastazione,
to know when we talk about cases of people who've been victims of acid attacks, how can these techniques can be used?
Nel senso che si può fare tanto, e in
Well,
questo
it depends on the severity of the cases. A lot can be done. Stem cells help a lot, for example, to make the tissue trophic again. When you have these acid attacks, usually the tissue, our skin, is replaced by scarring tissue, which then is stiff, painful, withdraws, and in this case, stem cells can be really very useful. Usually these are treatments that have to be repeated more than once, and it's not only used with acid attacks, but also in fire burns. And this is a field where they can be extremely useful.
Buonasera, io volevo chiedere
Good evening. I would like to ask you, since you're talking about the differentiation of these cells and of neurons, have you carried out tests also for neurodegenerative tests, diseases such as Parkinson's? Yes, that's the aim. Yes, the differentiation has been obtained in vitro, but the aim in this case is to apply them to such diseases and conditions. No? There's here another question.
Buonasera.
Good evening. In your experience, again in regenerative medicine, have you an experience with PRGFs? You mean the fibrin-rich matrix? Fibrin-rich matrix. Well, yes, I've used it. It's a little bit different from PRP. PRP is produced in liquid form, and then it can be activated, for example, through the thrombin of the patient or gluconated calcium, and this generates a coagulation from a clump. The release of growth factors is very fast, so it should be used within a few hours, and 90% of the release of growth factors happens in the first few hours. While in the matrix, in the PRF, in the platelet-rich fibrin, is a slower release, which means that it's a more solid matrix that can be actually suturated or grafted on to the wounds. It depends what you want. We used the PRP as a first-line treatment and then used the PRF at a later time to have the slower release. But in fact, from a clinical point of view, at least in my experience, I haven't seen a major difference on ulcers. As far as the other clinical applications, there again, you have to debate it. I mean, it's debatable. In some cases, it may be better to have 90% of the release immediately. In other cases, a more gradual release may be an advantage. Clinically, I think the end results were roughly the same. They were comparable. We used the PRP. Initially, I used to activate it because I liked the gel. It gave me the psychological ease of covering the wound, but in fact, I've seen that with the injection and also the topical application of the liquid matrix, it activates alone, because acting with the blood on the surface and also with the deep extracellular matrix, it virtually activates on its own. And I prefer an activation of this time rather than an external one, because when you activate externally, in any case, there is a certain loss of resources, which are the ones which mediate the formation of the coagulation. So I prefer it to happen rather than, but this is my experience at least. This lovely gel, it's just something which is very similar. You often say, I enjoy doing this. You're like manipulating our bodies. I feel as if I'm the other side. Well, it's a constructive amusement. It's the interest of the patient. For us, it's our life. In fact, the greatest satisfaction I have is when you can heal a wound like that, because it's never only always the tissue. There's a person who comes for every 2 or 3 days, and then the relatives come. It really is, even though with age and in time, you don't get used to it, but because you never get used to it, because in any case you get involved in it. But we have fun and we get to know our patient, and it's a great satisfaction. And we don't have to use any dirty bandages or anything like that. There's this relationship with the patients, I see, which is in fact a relationship with the audience that you very often don't have in other areas of GiovedìScienza, of Science on a Thursday. For you, it is important to talk about it with your patients, but it's also important in situations like this, It's important. It's important for me to be able to tell it here, which is why the GiovedìScienza prizes are really something which pushes researchers, which encourages researchers and people from other areas to try and transfer the complexity of research into very simple terms. As doctors, this is easy because it can be transferred. We have to explain this to our patients. And the patient needs to know what stem cells are and might be 80 or older and have different cultural background, and we have to have informed consent, and so we have to explain it. It's something that we got used to every day, and it's part and parcel of our job. A physicist could, in fact, have the luxury of being alone in a room. You can't. I don't know. But certainly it's very different. For us, it's an enormous problem because we have informed consent. And to be informed, the person must be able to understand what is being said. And that's very important. Are there any other questions? Yes. Very simply, I'd like to know if here in Turin or in Piedmont there is an area or there is a place where this technique is implemented. I can't really answer that question, but I'm sure that the University of Turin, I'm sure they do it. I know that they can do it. I don't really know exactly the name of the colleague or the center, but I'm sure that at the university they do it. Yes, the university hospital. I'd like to ask, the fat that is treated, can it also come from another person? No. That would be everybody's dream. No, unfortunately, because I'm thin, you see. No, unfortunately, it has to be your fat. We can't do that. Now, well, I hope that you'll be healthy. And there's a question from here. I just wanted to ask you also, in the present state, the national health system, does the national health system cover it? Yes, luckily. Well, if there is a pathology, if there is a wound, or if there is a scar, well, then generally it is covered by the national health system. There are variations on a regional basis, but on the whole, this type of procedure, as far, for example, as the adipose graft, the PRP varies according to each region, and of course it depends. Aesthetics are not covered. Cosmetic surgery is not covered by the national health system, but the rest is. Are there any other questions? Yes, there's one up there.
Buonasera. Rapidamente vorrei rispondere alla domanda delle signore, se ci sono centri a Torino.
Very rapidly, I would like to answer the question that the lady raised. Are there centers in Turin? Yes, there are. There are centers in Turin that are involved in this, in particular for the treatment of ulcers. A question. In the case of psoriasis, have you carried out any applications with adipose tissue, yes or no? And what is your experience? Personally, I haven't, although there's a reason to do so, because since they're immunomodulators, they could have an impact, a very good impact, on this type of pathology or disease. But is there research underway? I'm sorry, but I am not able to answer the question because psoriasis isn't in my field.
Ecco. L'ultima domanda. Poverina, la fate correre da una parte all'altra. Poteva alzare la mano poi di qua. È venuta dopo.
Last question, then. She's going to have to run from one side to the other with the roaming mic. First of all, please excuse me for having got the roaming mic. I'm a 3D specialist. I didn't quite understand What you physically print is the substratum where the cells grow on. You don't print the cells, do you? Well, it depends. Both. The cells can't be printed. You either print the substratum, which is then repopulated by the cells of the body, or you print the substratum. You deposit the cells on it, then they reach a certain degree of differentiation, and then you have the grafting. Again, it's an initial phase, because this graft has to be revascularized, so there is a synergy. We have technology, that biomedical engineers, which make it possible for us to have a matrix where the cells differentiate in a certain sense rather than another. We can also use growth factors for the immunodifferentiation of those type of cells in those tissues. It's still all early days, and it's multidisciplinary. Thank you very much.